First of all, I would like to say I'm so sorry that I can't speak Spanish at all. It's one of my goals for the next year. May I introduce myself? Do you think it's okay to introduce?
No. Speak, stop, wait me a minute. Buen día a todo el mundo. Bienvenidos a otro sábado de USPed. En esta mañana hermosa del Focus, tenemos el placer y el honor de presentar a Gabriela. Si me das un segundo, me quiero hacer algo. Ahí está. Ahí está. Tengo el honor y el placer de presentar a Gabriela Leal. Gabriela Leal la conozco a través de un webinario que hemos hecho a través de la SIC, la Sociedad Latinoamericana de Cuidados Intensivos, ha dado una charla hermosa y a partir de ahí surgió esta invitación, esta idea de que pueda acompañarnos en nuestros sábados de formación continua y de USPED. Así que, Gabriela, yo tengo acá tus referencias. Ahí está volviendo Alfredo, que justo se desconectó, que es nuestro anfitrión del día de hoy, así que ya vamos a dejarlo que él haga su trabajo de presentación, pero yo quiero tomarme este ratito para poder agradecerle a Gabriela por,
I'm back.
por tomarse este tiempo. So, thank you very much. And now, Alfredo, todo tuyo.
Sí,
Alfredo, ¿nos escuchas?
yes. So we're having a great session today with Dr. Grabriela Leal, who's joining us from Brazil. So right now we are Spanish talkers with Portuguese talkers presenting an English dissertation, but well, it's gonna be a great, yeah. I don't know Portuguese, she doesn't know Spanish, so we're trying to do our best with English. So
Shame on me.
but it's like Javi was saying, it's a great pleasure for us having you dissertation today in USPed Latinoamérica, which is a group of people who share knowledge and research and in point of care ultrasound, in pediatric point of care ultrasound. So Dr. Grabriela is the chief of ecocardiography of Instituto da Criança e do Adolescente do Hospital das Clínicas da Universidade de São Paulo. Did I mention it correctly?
Yes, that's correct.
She is also a postdoctora pelo Departamento de Pediatria da Faculdade de Medicina da Universidade de São Paulo. É cardiopediatra formada pelo Instituto do Coração, INCOR.
Thank you so much for your kind invitation. I'm so honored to be here today. I hope you enjoy. Please be free to ask me if you have any doubts. And today we are going to talk about echo as an adjunct in the clinical assessment of hemodynamics status in the pediatric intensive care unit. So first of all, I have to tell you that echo in the pediatric intensive care unit has much more to offer than anatomical descriptions and LV ejection fraction only. So today we are going to show you another valuable parameters that should be included in our evaluation in daily basis. So the approach to cardiovascular assessment and monitoring remains suboptimal, owing to an over-reliance on poorly predictive clinical markers such as heart rate and capillary refill time. Functional echo enables real-time evaluation of cardiac performance and systemic hemodynamics and guide therapeutic decisions. First of all, the old LV ejection fraction, old and good LV ejection fraction. Most of us are very familiar to ejection fraction. And so how do we measure this in using echo? First of all, the simplest form to calculate LV ejection fraction is the M mode. So we find just we choose a line that crosses right ventricle, septum, LV, and a posterior wall in diastole and in systole. So you have it, this line here. And we are going to show how all those chambers perform during diastole and systole. And we can measure linear distances here using the software of the machine. When we measure LV diastolic diameter and LV systolic diameter, the software can estimate the volume of the LV in diastole and the volume of the LV in systole. It's an estimation based on the linear measure that we have done here using the software. So how do I calculate LV ejection fraction? It's LV diastolic volume minus LV systolic volume divided by LV diastolic volume. And the normal value should be 55% or higher. So 55% or higher is the normal value of LV ejection fraction. And the method I have used is Takos methods. So Takos is the name of the method that we have used to calculate LV ejection fraction by the M mode. Here we have another form to calculate LV ejection fraction, and the name is Simpson's method. So this is the Simpson's method. And we use to calculate LV ejection fraction 2D echo, not anymore M mode. It's much more precise than M mode to calculate LV ejection fraction this way. We need a 4-chamber view and a 2-chamber view. They are 2 orthogonal planes. So the software can estimate the volume of each of those disks. And the software is going to add the volume of each disk to estimate diastolic as well as systolic volume. And again, the formula is LV diastolic volume, LV systolic volume divided by LV diastolic volume. And the normal value is also 55%. So here we use 2D echo in the method called Simpson's. And how to estimate LV output? It's also possible to estimate LV output using echocardiogram. First of all, we have to register VTI, velocity time integral, of the LV outflow Doppler. Here, I'm going to put my sample volume here, just in the outflow tract of LV, below the aortic valve. And this is the graphic I'm going to find. When I draw a line, an envelope of the Doppler flow, the software can calculate for me. The VTI is the distance. If you imagine a red blood cell sitting here in the outflow tract, during the systole of LV, the red blood cell is going to travel a distance inside the aortic vessel. And this distance is the VTI. It's the integral of the flow here in the LV outflow tract. So if the VTI is 11 centimeters, it means that a red blood cell that was sitting here just below the aortic valve during the systole or LV, it is going to travel 11 centimeters through the through aorta. And how can I estimate the outflow tract diameter? Here, when we have the peristernal long axis view, we can measure diameter of the outflow tract directly on the image. And we can easily calculate the radial of the outflow tract. It's just the diameter divided by 2. This is the formula of the outflow tract area, P multiplied by the radius elevated by 2. If I can measure the LV outflow area as well as the aortic VTI, when we multiply those two values, the result will be the volume that is effectively ejected each time the LV contracts. If you multiply the volume, the systolic volume, by the heart rate, and then you divide it by the surface area of the patient or the weight of the baby, we have the LV output. So it's an easy way to understand how to calculate LV output. And normal values of LV output are different when we compare preterm, term, or pediatric patients. We have to use different cutoffs of normal value, LV output, in fact. And there's another form to evaluate systolic function of LV that is much more precise than LV ejection fraction. We call it strain, the formation of LV during systole. Most of you must have read some papers talking about strain or LV deformation, myocardial deformation. And each of the LV segments are represented here in the 4-chamber, 3-chamber, and 2-chamber views. And this is a bullseye showing each segment and the percentage of shortening of each segment. So this segment is the basal segment of the anterior septal wall. When we say the strain is minus 18, it means that this segment has shortened 18% during systole. And we have normal values now, established cutoff values, and we can see here that this patient has some areas of low deformation. Why this patient has those areas of lower deformation? In fact, it was a patient with myocarditis. So inflammation can reduce the ability of the myocardium to strain, to reduce length during systole, as well as when we have problems with microcirculation, areas that are under, that receive lower blood flow can deformate less than areas with adequate blood flow. So we can study microcirculation using the bullseye as well. And that's another utility for strain, is to diagnose earlier cardiotoxicity of chemotherapy as well. So patients that are under chemo should be evaluated with strain, because before LV ejection fraction falls, we can also document reduction of the LV strain. So it gets lower earlier than LV ejection fraction. So we have time to treat those patients, not to interrupt the chemotherapy. And we can even just to change the type of chemotherapy I'm going to give to the patients with less cardiotoxicity as well. Another interesting aspect is that normally we are very concerned about LV systolic function, but we also have to keep in mind that LV diastolic function is also very important. When we receive a patient in the pediatric intensive care unit known to have, for example, chronic kidney disease, the LV may be preserved, still preserved, but those patients usually have diastolic dysfunction. If they come to you in a septic shock, for example, it's not advisable to give volume to this patient only taking in account the LV ejection fraction, which is preserved. Because if he has LV diastolic dysfunction, when you give volume, a large amount of volume or rapid amounts of volume, this patient may develop heart failure, because LV cannot receive all that volume. It's not easy for the LV to receive all that volume that you are giving. The myocardium is stiff, does not relax as it should. And we can combine conventional Doppler profile with tissue Doppler profile, which I'm showing here to you, to diagnose the type of diastolic dysfunction of each patient. So you don't have to know all the kinds of combination, but you must keep in mind that the echo should give you the diagnosis of LV diastolic dysfunction. It should be always evaluated when the pediatric cardiologist approach the patient. It's a valuable information to be written in the report. So ask your echocardiographer or pediatric cardiology to investigate diastolic dysfunction when you receive patient in the pediatric ICU. And we can tell you, combining both Doppler profile, the conventional Doppler profile through the mitral valve, as well as the tissue Doppler velocity profile acquired in the septal or lateral annulus of the mitral valve, we can combine both and give a diastolic diagnosis to you. If there is impaired relaxation, if we have pseudo-normal feeling, or a restrictive feeling, which is the worst. When we are talking about patients with pseudo-normal or restricted feeling, you can say that the final diastolic pressure inside the LV is elevated. So it's most patients with pseudonormal or restrictive physiology have chronic disease that justify the diastolic impairment. Now talking about pulmonary artery systolic pressure. How can we estimate systolic pressure of pulmonary artery? We can use the tricuspid regurg to do this estimation. Here we have it. The software can tell you what's the velocity of the tricuspid regurgitation, the maximum velocity. It's here. You don't have to calculate, although it's useful to know that the gradient is obtained by the Bernoulli equation, but most of the equipments are able to calculate the gradient between RV and right atrium, and you don't have to do any calculus, don't have to remember the formula. In this case, the gradient of pressure between RV and right atrium is 31 millimeters of mercury. So if the difference during systole of the pressure from the right ventricle and the right atrium is 31, and the pressure of the right atrium is usually about 5 to 10 millimeters of mercury, one can say the systolic pressure of the RV is 41 in this case. So we have to estimate the pressure of the right atrium, and then we add this pressure to the gradient that you have here, told by the software. It's very easy. So we have decided that 41 is the pressure, the systolic pressure of the RV. But during systole, the pulmonary valve is open. So pressures, when you compare pressures of the right ventricle and the pulmonary artery, they should be equal because the valve is open. And the pressures are going to be equal at the final moment of the systole. So if there is no obstruction of the RV outflow tract, we can say that the systolic pressure of the right ventricle is equal to the systolic pressure of the pulmonary artery. If we have tetralogy of Fallot or pulmonary stenosis, this is not true because I have obstruction in the outflow tract of the RV. We can only estimate systolic pressure of the RV using this technique of tricuspid regurgitation velocity if there is no outflow tract obstruction of the RV. And when we say that pH is present, pulmonary hypertension is present, if the tricuspid regurgitation jet velocity is equal or lower to 2.8, it's unlikely to have pulmonary hypertension. It's likely to have pulmonary hypertension when velocity is 2.9 to 3.4, and very likely to have pulmonary hypertension when tricuspid regurg jet velocity is higher than 3.4. And if you don't want to estimate systolic pressure, you can just look at the pattern of the flow through the pulmonary artery, through the pulmonary valve. If it's symmetric, you can say the pulmonary artery pressure is normal. When you have the asymmetric Doppler profile, probably you have pulmonary hypertension. And when there is a mesosystolic notch, it's like a W, the pulmonary artery pressure must be superior to systemic pressure. So just to see the pattern can tell you very much about the pulmonary artery flow pattern. Here we have the VTI. We can measure the VTI of the RV outflow tract as well as the LV outflow tract. It's similar technique. And here we have the normal values of preterm and term and pediatric patients' VTI of the pulmonary artery. So keep in mind that preterm and term infants have different cutoffs of normal values, and we must be aware of the gestational age, but as well of the days of life of the baby that is going to be examined. As you can see, the VTI, the pulmonary artery VTI, increases with time. So when you read the echo results, we must keep in mind which patient was examined. Another way to evaluate RV systolic function is FAC, fractional area change. And it's so easy to do this. We can draw a line just below the endocardial surface of the RV in diastole and systole. And this is the formula, taking into account diastole and systole, diastolic and systolic areas of the RV. And the normal value will be 35%. Another way to evaluate RV systolic function is tricuspid annular plane systolic excursion, or TAPSE. It's very, very popular to use TAPSE as a systolic function parameter using echo. And all the measures have a z-score. So we have to calculate the z-score for each patient we are dealing with. It's not a constant value, a constant cutoff. We have to always calculate the z-scores. And it's very useful when you are evaluating the same patient through days or 2 hours of those patients in the pediatric intensive care unit. So you can do the measure of TAPSE, and then we can reevaluate patients after measurement, after different strategies to take care of those patients. If you put them on nitric oxide, or if you put them under different types of ventilation, we can measure TAPSE as many times as you need. Here you have an example of the diaphragmatic hernia. It's a baby, a newborn baby, term infant, with 2 days of life. You can see the RV is severely dilated and hypertrophied. You can see the septum, interventricular septum, bulging into the LV. So this tells us that the pressure inside the RV is higher than the pressure inside the LV. Look at this, the foramen ovale, the septum, interarterial septum here. You can see it's bulged into the LA. For the same patient, we have calculated the systolic pressure of pulmonary artery. It's very high. It's higher even than the systemic pressure of this baby. And here we have the mesosystolic notch, which also says the same thing, that pulmonary pressure must be higher than systemic pressure in this case. But after murinon and nitric oxide, we have shown that this baby has increased the Z-score of TAPSE. So it was a good responder to the drugs and to the nitric oxides. And this baby was successfully operated. This is another baby, 2 days of life, term infant, high pulmonary artery pressure estimated by the Bernoulli equation. Here we have a very low VTI of the pulmonary artery, so the performance of the RV was severely compromised. And this baby did not survived. We could not operate this baby. This baby was deceived, unfortunately, because the function of the RV was severely reduced, and it was a very bad prognosis for this baby. Now we are going to talk about pericardial effusion. Here you have a short axis para-external view, and this area of no echoes, it's black. It represents the liquid that is collected around the ventricles, the pericardial effusion. We must evaluate the pericardial effusion in different views. So here we have the parasternal long X view, and we also have the area with no echoes here, posterior to the LV, as well as anterior to the RV. So we have liquid all around the ventricles and all around the heart. It's a big pericardial effusion. In the same case, we can see that the inferior vena cava does not change its diameter with aspiration or inspiration. It's severely dilated, and the diameter does not change using the M mode during expiration or inspiration. It's another sign of cardiac tamponade in this case. And here you have the clip. You can see the right ventricular free wall collapses during diastole and should not be like this. This is a sign of cardiac tamponade. See here that the right atrium wall also collapses, but it's a thin wall, easily collapsible. When you have collapsibility of the RV free wall, it's much worse than the right atrium collapsibility. So be wise, and when we have this kind of image, you must think of cardiac tamponade with compression of the free wall of the right ventricle. Here I have made this graph to talk about the physiopathology of cardiac tamponade. Here's a normal heart. We know that what drives flow from the left atrium to the left ventricle is the LV pressure gradient between pulmonary capillary wedge pressure and LV and diastolic pressure. When we inspirate, we generate negative pressure inside the chest. But this negative pressure is it occurs inside the lungs and inside the LV. So the gradient is preserved, although both pressures get lower during inspiration because of negative chest pressure. The gradient is maintained, so there is not significant variation between the velocities of flow from the left atrium to the left ventricle during inspiration or expiration. You can see the E velocity is kept the same during inspiration or expiration. But when we have cardiac tamponade, the negative pressure we generate during inspiration can only be sensed by the pulmonary capillary pressure. It lowers when you inspirate, but left ventricle and diastolic pressure does not change because the heart is covered with liquid. It's enclosed by the pericardial effusion. So the gradient is lower here during inspiration. That's why E velocity is lower during inspiration in mitral valve than during expiration. So this pattern of Doppler flow through the mitral valve tell us that we have cardiac tamponade. Here, the same patient I was showing to you. When the mitral Doppler profile in cardiac tamponade, when the velocity, the E velocity falls more than 25%, we can say this is a cardiac tamponade during inspiration. Now we are going to talk about fluid responsiveness. First of all, take 2 steps back. Why? We must think profoundly about this. What are the echocardiographic variables used to determine fluid responsiveness in shock? Are they useful in pediatric populations? Most of them were just described using adult populations. So that's why we are talking here, we are asking here if it's really useful in pediatric population. The first parameter is inferior vena cava collapsibility index. We use collapsibility index when we have self-breathing patients. Using the M mode and the subcostal view, we measure the inferior vena cava maximum diameter during expiration and inferior vena cava minimum diameter during inspiration. Why is that? Because during inspiration, there is negative pressure inside the chest, and it's easier for the blood that it is in the inferior vena cava to come through to the heart, to return to the right atrium. So IV inferior vena cava diameter gets lower, and during expiration, it's much more difficult to blood to come from the inferior vena cava to return to right atrium. So we have the maximum diameter of inferior vena cava, and the normal value of collapsibility index is here. Sorry for that. When we have at least 12% of collapse, or sorry for that. Here we can detect the maximum diastolic diameter of inferior vena cava and minimal diastolic diameter of inferior vena cava. And this is the sensitivity and specificity of the index. Now here, another way of estimating volume is the inferior vena cava distensibility index. We use it for patients under mechanical ventilation. Inferior vena cava and mode at the subcostal view is the preferred view. We can measure inferior vena cava maximum diameter during insufflation because the patient is mechanically ventilated, and inferior vena cava minimum diameter during expiration. And this is how we calculate the index. And what is the normal value. When sensibility index is equal or greater than 12%, we can identify patients who will respond to volume loading by an increase in cardiac output of at least 15%, with a predictive value positive and negative, just like that. This one is the best way to estimate volumes in pediatric patients, the one we usually use in Instituto da Criança, the respiratory variation in aortic blood flow velocity. When we have insufflation, it's for patients mechanically ventilated. When you have insufflation, we get lower values of aortic flow peak velocity, and during expiration, we have greater values of aortic flow peak velocity. When this formula tells us that this variation is equal or greater than 12%, we identify patients who will respond to volume loading by an increase in cardiac output of at least 15%. So the greater the difference, the better will be the response after volume overload. And there is usually a linear correlation between the delta V peak and the systolic volume gain. Which is the best? Which parameter is the best for pediatric patients? We have lots of publications talking about that. But most of the reviews show us that delta V peak, the aortic blood flow, is the best way to predict volume response in pediatric patients. And what is the best threshold value to use? We use 12%, but you can see by this review article that the cutoff values vary between authors. So it's still a problem. We use 12%. So which is the most reliable echo parameter? Most of the dynamic indices, including those based on arterial waveform, inferior vena cava, and plethysmography, lack predictive value in pediatric populations. And the possible reasons for that, it's higher chest wall and lung compliance, more compliant arterial vasculature, and lower ventricular compliance in children compared with adults. The most reliable parameter is the respiratory variation in aortic blood flow peak velocity, delta V aortic peak, as we have showed to you. And here a real example. It's a neonate, 10 days old, septic shock, positive blood cultures, hypotension, tachycardia, no urine, high serum lactate, acidotic, in use of the butamine, epinephrine, and norepinephrine. And the question of the intensivist was, is the baby hypervolemic? You see inferior vena cava is dilated. This patient is under mechanical ventilation, high frequency mechanical ventilation. Here, the same baby, you can see blood flow from right atrium to left atrium through the foraminal valley. It's blue, so the blood comes from the right atrium to the left atrium. It's the opposite that we should have, and it is explained by the fact that the pressures here in the right atrium and right ventricle are higher than in LA and LV. And here we have a tricuspid regurgitation jet, so we are going to use this to estimate systolic pressure of the right ventricle, but it must be higher than LV pressure. Here you can see systolic pressure of pulmonary artery is very high, higher than systemic systolic pressure. And here the VTI showing a very low VTI, 5.4 centimeters. So the performance of the RV is severely impaired. And here you can see the LV is underfilled. Septum and left ventricle posterior wall during systole almost touch each other. So this baby is really hypovolemic when we talk about left chambers. And he's trying to keep LV outflow with higher frequency. So the heart rate is elevated to maintain blood flow through the aorta. It's a way to maintain LV output. So if you give diuretics to this patient, it's going to get even more serious situation because the LV is underfilled, actually underfilled. And we can see the ejection fraction is very high, 94%. So if you just look to the ejection fraction, someone can say, no, this baby, it's quite good. The LV ejection fraction is quite good, but you have to see this picture here, that the LV is underfilled. And why is underfilled? Because all the blood volume is kept here in the right ventricle and right atrium because pulmonary vascular resistance is very high. So it's not easy to the blood to come from the right ventricle and get inside the pulmonary vessels because of the higher pulmonary resistance. After milrinone, what do we have? The baby still have pulmonary artery hypertension, but it's better than before. And we can see that the VTI, the pulmonary VTI is higher here. So the performance of the RV has improved after milrinone. It was an excellent choice to give the baby milrinone because we have relaxed pulmonary vascular bed and improved contraction of the RV. It was the best choice for him. And now you see the LV now has better volume, diastolic volume. Septum and left ventricle posterior wall does not touch each other during systole. And the ejection fraction is also very good. So now we have recovered urinary output. And the baby was much better than previously. You can see for chamber view before and after, the LV now feels better than here. So we did not give diuretics, we did not give volume, we just put the volume in the right side using milrinone. So that's why we use echo to really understand physiopathology, to guide our conducts, to guide our decisions, medical decisions inside the pediatric and intensive care units. Is echo mandatory? A complete functional echo is always welcome if performed by a trained and experienced pediatric intensivist or cardiologist. Decision based in a single echo view or parameter should be avoided. That's why I have showed you many parameters. Clinical and echocardiographic parameters should always be combined in order to set up the best therapeutic strategies. So it's highly recommended if you have trained and experienced pediatric intensivists or cardiologists to perform. And that's my opinion. It may be a little that must be a little biased because I'm a pediatric cardiographer, but that's what I think. And that's all. I hope you have enjoyed. If you have any questions, please be free to ask.
It was an excellent presentation.
Gracias.
Thanks. It was a great dissertation. Was one of the most enjoyable dissertations of in a long time because I was away for some focus sessions, but this one was really special, really interesting.
I
I
think
learned a
it's
lot. So I think it's a great material for learning, for intensivists, for pediatrics, for everyone who is at a learning position, and we can use that presentation as a didactic, as a learning material for those who are uh, in the learning process. So I especially congrats Dr. Leal for that excellent and practical presentation because it's really practical. It's not that one of those conference that is loaded with data, loaded with information. It's really practical from every
thank you so
slide.
much. And the cases are real. The real babies in our intensive care.
Yeah, I think that's the most important thing about point of view ultrasound. That is to the relation between the clinical situations and the echocardiography. Because sometimes when you go to the books, when you go to the learning materials, it's really different from the real life clinical scenarios when you have to integrate all the knowledge. You have to integrate all the evaluations of left ventricle, right ventricle, fluid responsiveness, etc., to understand what your patient needs precisely in that moment. So everyone who wants to ask the doctor for some questions regarding that presentation, please, this is the moment to ask her. Si alguien quiere hacer una pregunta a la doctora, especialmente sobre su excelente presentación, este es el momento. Adelante.
We have a question here talking about the difference of LV ejection fraction estimated by Taikos and Simpson. You know, Simpson is the best. When you're using a 2D echo machine. If you have 2D echo, the LV should be estimated using 3D echo, but not all the machines have 3D echo. So the best to use is Simpson. But when you're talking about functional echo, and the one that is going to perform the echo is not a pediatric physiologist, we recommend to use Taikos because it's easier to learn and it's easier to perform on daily basis, and it's quicker to perform on daily basis. So it depends on who is performing the examination and the machine that you have. Ideally, if you have 3D, use 3D. But if you are a pediatric intensive care doing functional echo, so use the Taikos method because it's easier and you are not so mistake. You're not going to do the wrong measure. Feliz Navidad.
Question. Merry Christmas. Feliz
Parece
Natal,
que
¿no?
no hay más preguntas. Parece que no hay
Ya,
más preguntas.
quisieras hacer una sola, hacer una pregunta, Javier.
No, acá estoy agradeciendo, perdón. Alfredo, dale.
Sí, I would like to ask if what do you think about automatic measurement programs of the new ultrasound machines? Do you have any doubts, any considerations about those machines who have automatic BTI, automatic left ventricle ejection fraction? What do you think about?
I love this. I love this. Really, really love it. And I use it for the strain as well. We have now through artificial intelligence, all the softwares we use can estimate automatically the deformation of LV and of RV and of the LA as well. So that's automatically calculated, and we can change slightly if you don't agree with the measurements. And the same can be done to the VTI or the ejection fraction. It's great, very, very great. Why do I think it's great? Because we spend less time doing the measurements. You can adjust if you don't agree, but the whole work is done quick, much more quicker than if you have to measure each of them. So it was a great advance to have all those measures done by artificial intelligence. I'm so fond of it.
Yeah, I think the same for the critical care and emergency scenario. It's perfect. So once again, I would like to thank you for being with us today and giving us all this excellent presentation.
Thank you. I hope you have enjoyed.
And also Merry Christmas.
Oh, thank you for you. Feliz Navidad, you say.
Feliz Navidad y feliz Año Nuevo.
Oh,
Feliz New Year, Happy New Year, Happy 2024 for everyone.
Thank you so much.
Thank you very much. Thank you very much, Gabriela. Thank you very much, Alfredo.
Come to visit us in Brazil when you have time.
¿Cómo?
We live in São Paulo. Come to visit us when you have time. We live in São Paulo.
Voy corriendo. Yo estoy
What?
running. I'm running. Thank you very much, Gabriela. Thank you very
so
much, Alfredo. Hermosa
Thank you.
sesión. Primera con invitado desde Brasil. The first time Brazilian speaker. I'm so happy. And les deseo a todos hermoso fin de semana. Good and happy weekend. Goodbye, everyone.
Thank you.
Bye-bye.